I'm Dr. Philip Levy, Professor of Emergency Medicine at Wayne State University, where I also serve as Associate Vice President for Translational Science. And I'm very fortunate this morning to be here with Dr. Derek Chu. Derek?
Hi, I'm Derek Chu. I'm an interventional cardiologist and I'm the Director of Cardiology at the Victorian Heart Hospital.
Derek, you're presenting some really interesting information on your RAPIDx AI study at ESC. Can you tell us a little bit about the study and what you found?
Thanks, Phil. So the motivation for this is that we wanted to be able to implement the fourth universal definition at scale in emergency departments with rural and metropolitan centres. And the only way that we figured we can do this is actually through AI support. So what we did was generate an algorithm based on the clinical experience of patients who had come through our system, where we adjudicated their events according to the universal definition, and then implemented this algorithm in the cloud, if you like, sitting over the emergency departments to help with the decision support of diagnosing patients presenting to those emergency departments. But then we cluster randomized this. We took 12 hospitals, we divided them into two groups randomly, and half the groups got the access to the algorithm and the insights. The other half didn't. So we've then followed these patients. The intention was to actually follow them for 12 months, but we're actually seeing a much greater event rate than anticipated. And as a consequence, we made the decision that we would truncate the study at 6 months, having more primary endpoint events than we anticipated, and presenting them here at the ESC. So in a 7-month enrollment period, we managed to capture over 1,400 patients, 14,000 patients. And of those, about 5,400 patients had myocardial injury, and 3,029 patients had myocardial injury, which was thought to be associated with a cardiac cause. Overall, the groups were well balanced, and we saw that there were some modest changes in practice. So in patients where the algorithm had phenotyped the patient to be a type 1 MI, we saw an increase in statin use and an increase in P2Y12 inhibitor use, a little bit more MRA inhibition, but no actual increase in invasive management, angiography, or revascularization. In the much larger proportion of patients who were deemed not to be type 1 MI, i.e. type 2 MI or acute injury or chronic injury, that we didn't see much in the way of a change in pharmacology. We saw a little bit less beta blocker use, but we did see a reduction in angiography and revascularization. Overall, by 12 months in the primary analysis group, the patients with a primarily a cardiac initial assessment, we saw no overall difference in cardiovascular death, myocardial infarction, or cardiovascular readmission. However, if you looked in the larger population of patients with myocardial injury, we saw that the point estimate favored the intervention, but again, didn't reach statistical significance. And in the overall population, including all the 14,000 patients, there was, again, a point estimate favoring the intervention, but the difference didn't quite reach statistical significance. Interestingly, if you excluded the patients who presented with ST elevation myocardial infarction, 165 of them, then the difference between the intervention and the control are actually significant. And again, not terribly surprisingly, in patients deemed to be type 1 MI by the algorithm, a strategy of early invasive strategy of coronary angiography was associated with a benefit, but no benefit was seen with this strategy if you were deemed to be non-type 1 MI. So it reinforces, if you like, the evidence that we can identify patients who are at risk of recurrent events that can be impacted by guideline-proven strategies.
Very interesting stuff. And again, congratulations on an amazing, monumentous task that you undertook, getting these hospitals on board, getting that many patients enrolled. Given that you did impact practice a little bit, right, and you changed patterns of decision-making, why don't you think there was a bigger impact?
So we sought to nudge clinical practice. We didn't really, we weren't dictating that this is what the clinicians needed to do. we did leave the final decision and therefore the responsibility of that decision with the clinicians at the time. Obviously, structural factors in the health system will determine who gets an angiogram. In what I mean by that is availability is an important factor. We all know the availability of cath labs and patients being admitted to hospitals that have access to cardiology services are factors that drive the practice locally. And we did not change any of that. We didn't change that dramatically. If we're going to leverage more benefit from these insights, we are going to need to think about how structural changes or how practice changes are, I don't want to use the word enforced, but more strongly encouraged potentially by factors such as availability, ease of referral, and issues around long-term follow-up.
Yeah, I couldn't agree more. I mean, human element is always the difficult thing to account for in all of this. And but given the inevitability of AI in medicine, right? We're seeing this in all manner of what we do in practice. How would you, think about maybe the next steps? What would you want to do for further work around this? And what do you think could help enhance success of this concept?
So I think that we shouldn't underestimate the effort it takes to deliver AI into the clinical workspace. If we look at the AI environment at the moment, lots of it is really about the refinement of diagnostics. And at one level, this trial is really the refinement of a diagnostic clinical characterization of a syndrome. But what we're going to need to do is adapt and evolve how we deliver care together with the AI insights if we're going to actually deliver improvements in outcome. And to do that, we need to build environments and systems where we can do that iteratively and do that in a deliberate, measured, evaluatable way, as it isn't going to be a sudden instant change, but rather building on prior experience to change the health system slightly, look for an improvement, change it more, look for the improvement until we evolve the system in response to the AI insights.
Yeah, an iterative nature. Thank you so much, Dr. Chu, for sharing this quick preliminary look at the work you're going to present in the next coming days. And again, congratulations on just an amazing research endeavor and helping to guide the field as you've been doing for a number of years.
Thank you very much. Thanks for the opportunity, Phil.
Nice to speak with you.